Imagine you're operating on a patient with deep infiltrating endometriosis of the rectum. Your surgical instinct, I mean, the training ingrained in almost every surgical discipline, is to eradicate the disease entirely.
Right, you take wide margins.
Exactly. You remove the affected area, and you ensure absolutely nothing is left behind. But what if doing less? What if meticulously preserving that complex pelvic anatomy actually guarantees the exact same functional quality of life a full decade later?
Yeah, it really challenges a very traditional, almost comforting surgical philosophy. Do you prioritize completely removing the disease at the cost of altering the patient's native anatomy, or do you prioritize preserving that anatomy and kind of accept the risk of leaving microscopic disease behind?
And for you, the endometriosis specialist listening to this deep dive, we know this isn't just some abstract debate. This is a very real, high-stakes choice you have to make during your consultations. When you are looking at imaging of a large rectal nodule, do you opt for a conservative excision, or do you commit to a radical segmental resection? You are constantly looking for the most definitive, cutting-edge data to guide that decision.
Which is exactly why today we are looking at data that the gynecological surgery community has been waiting on for literally 10 years.
Yes, exactly. Today's mission is to unpack the highly anticipated 10-year follow-up data from the Endure randomized trial.
A massive undertaking.
It really was. This was a huge longitudinal effort authored by Dr. Horace Roman alongside an extensive team of researchers, including Adriana Maria Davidescu, Adrian Kustani, Abhishek Pangeshkar, and so many others, primarily driven by the cohort at Riam University Hospital.
Right.
We are going to definitively compare the long-term recovery, the functional outcomes, and the recurrences between these two primary surgical techniques.
But, before we jump to the 10-year finish line, we need to establish exactly who is in this trial, because the clinical implications here are highly specific.
Definitely set the stage for us.
So, the Endure team followed a cohort of 55 women. The baseline parameters for inclusion required patients to have deep endometriosis infiltrating the rectum up to 15 centimeters from the anus.
Okay.
The nodules had to be substantial, 2 covering an area over 20 millimeters in diameter over the muscular layer and encompassing a maximum of 50% of the rectal circumference.
So we need to be really clear here for the listeners. We aren't talking about tiny superficial lesions. These are complex, deeply embedded cases.
Precisely. And the location parameter is vital. If you are dealing with an ultra-low rectal nodule right on the anal verge, removing that section carries a much higher risk of low anterior resection syndrome.
Right, where the patient essentially loses the storage capacity of the rectum.
Exactly, leading to severe urgency and pelvic floor dysfunction. Because those ultra-low cases carry different mechanical risks, you cannot automatically extrapolate the Endure findings to them. This data is specifically for those larger mid to upper rectal nodules.
Okay, that makes total sense. So with that baseline established, let's look at the actual interventions. How did the researchers divide these 55 women?
They randomized them into 2 arms. The conservative arm consisted of 27 women. The intervention there was nodule excision, achieved either by shaving the disease off the bowel or performing a disc excision.
Which is basically cutting out just the affected patch of the rectal wall and closing it, right?
Exactly. Now, the radical arm, which had 28 women, underwent segmental colorectal resection. That's where the entire disease cylindrical segment of the bowel is removed and the 2 healthy ends are reconnected.
And what exactly were they measuring over this decade to determine which approach was technically better?
They were tracking a primary composite endpoint of unfavorable functional outcomes. Basically, they were looking for the presence of long-term digestive or urinary distress.
Things like severe constipation.
Right, which they defined mechanically as having only 1 bowel movement in over 5 consecutive days. It also included frequent bowel movements, like 3 or more a day defecation pain, anal incontinence, or bladder dysfunction based on standardized urinary symptom profiles.
Oh, okay. Here is where the findings are going to turn some heads. At the 10-year mark, the results were incredibly close. The data shows that 74.1% of the conservative patients and 71.4% of the radical patients experienced at least one unfavorable symptom.
It's remarkably similar.
Okay, let's unpack this for a second. If we think about the rectum as a critical piece of plumbing, segmental resection is like cutting out a damaged section of pipe entirely and fusing the 2 healthy ends back together.
A good analogy.
Right. It removes the problem, but alters the fundamental structure, the reservoir capacity, and the tension of the pipeline. Conservative excision, on the other hand, is like going inside that pipe and meticulously patching a specific hole or scraping off the rust.
Right, you preserve the original pipe, but you risk leaving microscopic flakes behind.
Exactly. But if the functional outcomes are essentially identical, roughly 74% versus 71% having complications, I have to push back a bit here.
Go for it.
Wasn't the entire original hypothesis of the Endure trial that conservative surgery would yield better functional outcomes? Like less cutting, better function. Since the results are a statistical tie, did conservative surgery technically fail this trial?
Well, if we look through a strict, purely statistical lens regarding superiority, yes, the trial failed to prove that conservative excision is unequivocally better for long-term bowel function.
But I'm guessing there's a clinical but coming.
A massive clinical but. We have to recontextualize what a victory looks like in this specific anatomical space. Proving equivalence is still a huge win.
Because it means you don't have to be as radical.
Exactly. By proving statistical equivalence, this trial confirms that conservative excision remains a highly effective, reasonable alternative to radical surgery for these large nodules. You are preserving the patient's native anatomy, their native rectal reservoir, without sacrificing long-term symptom relief.
That is a big deal.
It is, and we really have to look past that binary, unfavorable symptom percentage for a moment.
Why is that? I mean, a 70+% complication rate sounds incredibly high on paper to a patient.
It does, but those strict clinical definitions don't always align with a patient's lived experience. When the researchers asked the patients subjectively how they felt, nearly 60% of women in both the conservative and radical groups reported having normal bowel movements at the 10-year mark.
Wait, really? 60% felt normal? Even with that 70% complication rate?
Yeah, because a patient might technically trigger a flag on a clinical questionnaire because they occasionally have to strain or they experience minor urgency once in a while. But to them, in their daily life, their plumbing feels functional and normal.
That subjective measure is so important. But that high rate of equivalence naturally leads us to question the bedrock of the data itself.
The dropouts.
Yeah. Anyone who works in longitudinal research knows that patients inevitably vanish after year 3 or 4. They move, they lose touch, they stop answering surveys. If the patients with the worst outcomes simply dropped out of the study out of frustration, this whole equivalence argument falls apart entirely.
It is basically the Achilles heel of surgical literature. The loss to follow-up rate usually completely invalidates 10-year conclusions.
Yet, the Endure team managed something incredible here. Only 5 out of the 55 patients, that's just 9.1%, failed to complete the full 10-year follow-up.
Which is unheard of.
Right. And the specific reasons why they dropped out actually highlight the messy reality of tracking human biology over a decade. For instance, one patient underwent a gender change and chose to step away from a study that was closely tied to their previous female status.
Which makes complete sense.
And another patient developed a severe case of lumbar degenerative disc disease.
And that lumbar disc detail is crucial from a data perspective.
Why is that?
Well, severe spinal disc disease causes referred nerve pain throughout the pelvic region. For that patient, it became mechanically impossible to isolate and accurately report whether her pelvic pain was coming from a rectal endometriosis recurrence or from her compressed spinal nerves.
Oh, wow. Right, the data would just be noise at that point.
Exactly.
And then 3 other patients were simply lost to follow-up. But we still have that lingering doubt. How can we be absolutely certain those lost patients didn't drop out because their original surgeries failed miserably? Doesn't that risk skewing the final comparison?
The authors anticipated this exact criticism, and the statistical lengths they went to in order to preserve the data's integrity are really quite brilliant.
What did they do?
To ensure they weren't artificially inflating the success rate, they utilized an intentional worst-case scenario rule for their primary analysis. They arbitrarily assigned an unfavorable outcome to all 5 of those lost patients.
Wow, so they mathematically punished their own data set?
Precisely. They assumed the absolute worst.
So even the patient who left because of a gender change, who might have had perfect bowel function at their last visit, was recorded as a surgical failure in the final tally.
Yep. And even with that heavy penalty applied, the between-group comparison remained non-significant. The 2 techniques were still equivalent.
That is robust.
But they didn't stop there. They ran multiple statistical stress tests, specifically generalized estimating equations, or GEE, and linear mixed models.
Okay, for those of us who aren't biostatisticians, how do those models actually work in plain English?
In plain terms, these are algorithms designed to handle missing data in longitudinal studies. Instead of just looking at the final snapshot at year 10, they analyze a patient's entire trajectory over time. The models predict what those missing patients' scores likely would have been based on their earlier
Well,
check-ins.
that's clever.
They also ran a complete case analysis that simply ignored the dropouts. And across all of these different analytical models, the result held firm. The robustness of this data is truly exceptional.
It is incredibly reassuring. However, when looking through those statistical models, I did notice something in the GEE analysis that gave me pause. It showed a slight statistical time trend of deterioration, something like an odds ratio of 1.087 per year.
Right.
And mechanically, that makes it sound like these patients' digestive systems were slowly failing as the decade went on.
That is a very astute observation, but what's fascinating here is that this apparent deterioration is actually a mathematical quirk. It is an artifact of how they designed the primary endpoint.
How does that happen?
Well, the primary endpoint was a binary composite.
Like any symptom equals a 1, no symptoms equals a 0.
Exactly. And because this is a cumulative longitudinal study, if a patient developed even a mild temporary case of anal incontinence at year 2, they triggered that endpoint. And mathematically, they carried that unfavorable flag forward to year 3, year 4, all the way to year 10.
Oh, I see. It's like a cumulative memory in the data.
Yes, exactly.
So even if that patient went to pelvic floor physical therapy, changed their diet, and their symptoms completely resolved by year 5, the statistical model still remembered them as a failure at year 10.
That's it. It's a recognized limitation of using binary endpoints over long periods. To prove this was merely a statistical artifact and not actual physical deterioration, the researchers looked at continuous specialized scoring systems.
Like which ones?
They used the Gastrointestinal Quality of Life Index, the CASE score for constipation, and the Wexner scale for incontinence. These scores measure the severity of symptoms in real time, rather than just flagging a historical event.
And what did those continuous scores reveal about the patient's actual day-to-day physical function?
They remained beautifully stable from year 1 onward.
That's amazing.
Yeah, there was no clinically meaningful deterioration over the 10-year period. The continuous scores prove that the surgical approach, whether excision or resection, does not lead to progressive functional decline. The structural relief and digestive function they achieve at year 1 is highly predictive of how their plumbing will function at year 10.
That is a massive relief. It means the functional outcomes are comparable, the data is rock solid, and patients maintain their quality of life over the long haul.
Right.
But functional outcomes are really only half the battle when we're talking about endometriosis. If a conservative excision preserves the anatomy but allows the disease to rapidly grow back, it's a moot point.
Which brings us to the long-term clinical risks, recurrence and secondary surgeries.
Exactly.
The primary fear surrounding conservative surgery is that by leaving the rectal tube intact, you are inevitably leaving microscopic disease in the bowel wall that will just roar back to life.
But the 10-year data completely dismantles that fear. The recurrence rates for rectal endometriosis were phenomenally low in both groups. We are looking at a 7.4% recurrence rate in the conservative excision arm versus 3.6% in the radical segmental resection arm.
And statistically, there is no significant difference between those two numbers.
That is a profound validation for conservative techniques. It proves that you can achieve a durable, long-term clearance of the disease without needing to completely resect the bowel in every single case.
Absolutely.
Now, we do need to address reoperations. While the rectal recurrences were impressively low, the overall secondary surgery rate across the decade was not 0. The study notes a 32.7% reoperation rate.
Yeah, which is about 1 in 3.
Right. And if you are sitting across from a patient telling them they have a 1 in 3 chance of needing another surgery, might sound incredibly alarming.
It does sound high initially, but we have to look at the clinical indications for those second surgeries. They're not primarily for failed rectal procedures.
Oh, really?
Importantly, only about 11% of the secondary surgeries were performed for pain relapse. The majority were actually related to fertility intentions.
What kind of fertility-related surgeries?
Things like managing a hydrosalpinx, where a fallopian tube becomes blocked and fills with fluid, or removing ovarian cysts that developed years later. Endometriosis might have been successfully cleared from the bowel, but it is a systemic, highly inflammatory disease. It can still mechanically affect the reproductive organs over time.
That systemic nature leads to a really vital clinical takeaway regarding that 11% who did need surgery for pain relapse. The data highlighted a very specific subset of patients, didn't it?
It did. For women who had their uterus conserved during the first surgery, but who did not desire future pregnancies, 10% ultimately required a hysterectomy, an average of 7 years later.
And the driving factor there was usually adenomyosis, right?
Yes. The deep rectal nodule was successfully handled during the primary surgery. But the adenomyosis, where endometrial tissue grows into the muscular wall of the uterus itself, progressed over the decade and eventually caused unacceptable, debilitating pain.
If we connect this to the bigger picture, how should this specific data point alter a specialist's preoperative consultation today?
It strongly suggests that for patients with absolutely no pregnancy intentions, you should be having a serious, proactive discussion about a concurrent hysterectomy during that very first primary rectal surgery.
Right, just handle it all at once.
Exactly. By addressing the uterus and the potential for adenomyosis right then and there, you could significantly reduce their long-term risk of requiring a second highly complex surgery for pain relapse down the line. It shifts the paradigm from just reacting to the most pressing rectal nodule to comprehensive long-term disease management.
That is incredibly practical, actionable advice. Now, speaking of the uterus and the reproductive system, I want to transition to the fertility outcomes because this is where the data becomes truly paradigm shifting.
The fertility data in this 10-year follow-up is arguably the most critical revelation for younger patients.
We had 34 women in this cohort who expressed a post-operative intention to conceive over the following decade. The pregnancy rate for those women was a staggering 85.3%.
And it wasn't just positive pregnancy tests. They had a live birth rate of nearly 80%.
Wow.
But the most vital mechanism to understand here is the conception mode. 64.4% of those pregnancies were conceived naturally.
Naturally. After undergoing major complex surgery for deep infiltrating rectal endometriosis, nearly 2/3 of the women who got pregnant did so without assisted reproductive technology.
It's phenomenal.
Why is that natural conception rate so biologically significant?
Because there is a very pervasive paradigm in the reproductive field that infertile women with severe bowel endometriosis should automatically be directed to first-line IVF before even considering rectal surgery.
Right.
The assumption is that surgery is too functionally damaging to the pelvic organs or too risky for ovarian reserve. They view IVF as the safer initial bet.
But biologically, IVF in that scenario is trying to implant an embryo into a highly toxic, inflamed environment. Deep infiltrating endometriosis floods the pelvis with inflammatory cytokines.
Precisely. And this data directly challenges that IVF first notion. It proves that first-line surgery is a highly valuable mechanical strategy. You go in, you meticulously excise the disease, you restore the normal pelvic anatomy, and you drastically reduce the systemic inflammatory burden.
Which changes everything.
It does. By removing that toxic environment, you wake up the reproductive system and unlock this incredibly high rate of natural conception.
It completely reframes the treatment algorithm. Obviously, age and baseline ovarian reserve still dictate a lot of this, and the authors are careful to note that 25% of these patients were under 27 years old at the time of surgery.
True.
So you can't automatically promise these exact percentages to, say, a 39-year-old patient.
Right. The biological clock still applies. But for young women with large rectal nodules, this data proves that meticulous surgery isn't just about pain control or bowel function. It is a profound mechanical fertility restoration tool. And because both the conservative and radical approaches yielded these high fertility rates, the surgeon can confidently choose the technique that best fits the specific anatomy of the nodule.
Knowing the fertility prospects remain excellent either way.
Exactly.
So let's synthesize this entire deep dive for the specialist listener trying to apply this to their practice tomorrow.
Let's do it.
The 10-year Endure data proves, with incredible methodological rigor, that conservative excision shaving, or disc excision, is just as viable and effective as radical segmental resection for large rectal nodules. It offers stable, long-term digestive function that does not mechanically deteriorate over time. It boasts remarkably low bowel recurrence rates of under 8%, and it supports phenomenal natural fertility prospects by clearing the inflammatory pelvic environment.
It definitively moves conservative surgery from the realm of a, hopeful alternative to an evidence-based standard of care for large DI or nodules whenever it is technically feasible.
It gives you the concrete evidence you need to feel confident preserving that native rectal anatomy. But before we wrap up, I know there was one final puzzle buried in the subjective data that you wanted to highlight.
Yes. There is a psychological puzzle here that I think every clinician needs to deeply consider when managing long-term recovery. The the researchers didn't actually ask the patients the subjective question, do you consider your bowel movements to be normal? Until the 2-year mark.
Okay.
And at year 2, only 33% of the patients said yes, but by the 10-year mark, that number had jumped to over 60%.
That is a massive discrepancy.
Yeah.
Because as we discussed, the continuous mechanical scoring systems, the Wexner and Canis scales, show that their actual physical bowel function remained essentially flat and stable from year 1 onward.
Exactly.
Their digestion didn't suddenly improve mechanically between year 2 and year 10.
Right, the physical plumbing didn't change at all. Which means what we are observing is a profound psychological adaptation. A symptom that feels traumatic and highly abnormal at year 2, say, a slight urgency or a need to constantly manage dietary fiber, eventually just becomes the accepted rhythm of life by year 10.
Wow.
The patient's psychological threshold for what constitutes normal fundamentally shifts. The symptoms become less intrusive, less embarrassing, and simply become their new baseline.
That is fascinating. It means healing from this level of complex surgery isn't just about the physical tissue remodeling.
No, it's about the parent remodeling their expectations of their own body. I invite you to consider how your own patient's subjective perceptions of healing might evolve over the long term. Are we just managing their physical anatomy in the immediate postoperative window, or do we need to do a better job of guiding them through a multi-year psychological adaptation?
It completely reframes the timeline of patient support. When you step into that operating room, it isn't just about finding the widest margin to make yourself feel surgically secure. It's about navigating a highly complex anatomical map, choosing the path that preserves as much of the patient's native self as possible, and then giving them the time and support to thrive in that body for decades to come. Thank you for joining us on this deep dive. We encourage you to take these insights, the statistical confidence and conservative excision, and that remarkable fertility mechanism, and apply them to your very next surgical consultation.